All right. Well, someone lost their mind and said that I should present 50 slides in an hour, and they don't know the level of ADD that I suffer from. So that's probably not going to work, but we're going to try our best. So the point is that I'm going to be very animated and sometimes very loud. And the point is to get you excited about fatty liver disease, or as we now call it, MASH. Some overview. This is kind of what Dr. Rowe just talked about. So this particular program, along with the medical education resource, is built by the Chronic Liver Disease Foundation, which I'm a part of, and the Global NASH Council. And again, it's really meant for any provider that treats patients with MASH. We'll talk about the NIT algorithm that's recommended in routine clinical practice to treat and find patients with advanced liver disease from MASH in the US. And then the 3 phases of management. First, lifestyle. Second, medication. And third, thinking about experimental therapies or clinical trials that your patient might be eligible for. That's me when I was young and beautiful. Okay, disclosures. Those are my disclosures. All right, so hopefully by the end of this, you'll be able to tell me all about epidemiologic impact of MASLD, the use of NITs or non-invasive testing in MASLD. We'll talk about the lifestyle-based treatment. I will tell you ahead of time that I have very strong opinions on lifestyle-based treatment. So I might not agree with the slides, but I've agreed to present them. And I will give you my own opinion at the same time. Again, remember, the opinions are the speakers, not anyone else's. We'll talk about the currently approved treatment for MASH, as well as some of the medicines that are in development. We already talked about this. Do the pretest. Sign in and do the post-test, and then you will be good to go with your CME. All right, and this particular activity is sponsored by Madrigal. All right, so I think everybody knows that MASLD is a highly prevalent disease, just like obesity, just like diabetes. But I think what's underappreciated is how quickly the prevalence of MASLD is growing. When I first started giving talks as an attending, it was 25%. And over 10 years, it's grown to well over 35%. And in some studies, over 38%. In parts of Chile, it's growing by 2% every year, right? So this is a very, very rapidly growing disease. And when we think about the more dangerous version of MASLD, MASH, that can lead to advanced liver disease, cirrhosis, liver cancer, the prevalence is really high. 5% sounds like not that much. But that's 16 million people in the U.S., according to recent census data. And you can see that it really affects all over the world, right? 5% is pretty average across the world, but there's parts of Latin America where it's up to 7%. And it's not just adults, right? Look at the prevalence in pediatric patients in South America. 25% of patients of kids in South America have MASLD. And, there's going to be a significant portion of them that have that more dangerous version. And when we think about who has the most dangerous versions of MASLD and who are most likely to have it, the reason they changed the name from NASH to MASH is to recognize this disease is metabolic dysfunction-associated. So probably the component of the metabolic syndrome that affects fatty liver disease or steatosis the most is diabetes. And when we look at our diabetic population, the prevalence is upwards of 70%. That's crazy, right? So I will just, again, ADD. There is a study where people did random screening through an endocrinology clinic of diabetic patients using non-invasive testing, MRE-based elastography. And 14% of patients that were just randomly screened in a diabetes clinic had advanced fibrosis, so bordering on cirrhosis. 6% of them had undiagnosed cirrhosis. And just in this study, research study, they found 2 people with liver cancer undiagnosed and 1 person with gallbladder cancer. Imagine if we were doing that all around the world, right? So it just shows that there's a very high prevalence, and it's not just fat in the liver, it's people that have life-threatening diseases from it. And again, the growth of MASLD in the diabetic population is similar to the growth of diabetes as itself, just rapidly growing, and obesity over time. All right, now these two diseases are really interrelated. I don't want you to think that, hey, diabetes causes MASLD or MASLD causes diabetes. It's really both of those two things. It's a synergistic relationship, if you will. So people that have MASLD, hepatic steatosis, they have increased insulin resistance. They have increased risk of atherogenic dyslipidemia and increased risk of cardiovascular disease. The same is also true that the presence of diabetes drives MASLD, right, as you've kind of seen. So think of this, that's why it's not NAFLD anymore. It's not just non-alcohol related, it's metabolic dysfunction associated. So when we think about long-term outcomes, especially mortality for patients with MASLD, when we're talking about just pure MASLD, just fat in the liver, the entire spectrum, the death rate is the last bar on that graph. You can see that it's 17, the 17 per 1,000 person years. And that is higher than the death rate in the general population at 8. But what are the things that cause death in patients with MASLD? The majority is cardiovascular death, and that's the green bar there. They also die from extrahepatic cancer. So when we think about that, what is that? Those are obesity-related deaths, obesity-related metabolic disease and obesity-related cancers. And there is an increased signal of liver-related death, but 60% of the increased death rate for patients with MASLD is caused by cardiovascular and metabolic disease. Now, the story changes when we think about MASLD cirrhosis. So now we see that the death rate compared to the general population at the bottom is exceedingly high, 10 times higher than the general population. But what are they dying from? They're dying now from liver-related death. So the idea is that early in MASH or MASLD, it's cardiovascular death and metabolic death, right? Or obesity-related. And then later in MASH, when you have more advanced fibrosis, the death is caused by the liver. Okay, and this is old data actually from 2018, just showing that metabolic syndrome itself is associated with mortality. This is part of what drove the definition of metabolic syndrome X right back in the day. So you can see that once you achieve 3 components of metabolic syndrome, your mortality is incredibly increased, a threefold increase. And that's looking at survival probability. The other thing that's really interesting, you could create this same graph and look at the probability of having advanced fibrosis in the liver. The more components of metabolic syndrome you have, the more likely you are to have advanced fibrosis of the liver. Okay, and fibrosis is ultimately king, unfortunately. So when we're trying to find the clinical outcome that is the best predictor of liver mortality, it's fibrosis. At early stages of fibrosis, stage 0 or stage 1, the increase in mortality is mild. But at stage 2, there's this inflection point, and suddenly there's this exponential rise in mortality once you hit the later stages, stage 3 and stage 4. So that's why fibrosis being the predictor, that's the thing we want to target the most. And we do know that if you can cause the fibrosis to get better, that the patient has less bad outcomes. So this was data from the STELLAR-4 trial, which was a clinical trial looking at simtuzumab, as well as data from the NASH CRN, probably the best characterized clinical database of patients with NASH. And what they found was that if patients had fibrosis regression, either by natural history or by medication in the clinical trial, they were far less likely to have liver-related events, including liver decompensation, liver transplant, and death. So improving the fibrosis is associated with improvement or decreased rates of liver-related poor outcomes. So that obviously is why we need to be able to determine who has fibrosis. And when we think about MASH pathology, it's important that we want to stage their disease because, again, we want to know who has the type of fatty liver disease that is going to progress, who has fatty liver disease with cell death, with fibrosis. And it changes not only how we would think about them, but how we take care of them. So early MASLD, where there's just fat in the liver, all that we're really focusing on is lifestyle change, right? Because we know those are the patients that die of cardiovascular death. Even early MASH, when there's a little bit of inflammation in the liver, that's not, the focus should really be about metabolic syndrome. But once we get to stage 2 and stage 3 scarring, or we get to cirrhosis, then we need to start really focusing on how do we get liver-directed therapy. That doesn't mean you ignore the metabolic syndrome. Of course, we still need to continue to do that, but we can't ignore the liver. And so that's when we start thinking about medication-based therapy, surgical-based therapies, and more advanced therapies. And back in the day, we used to have to do a biopsy on everyone to be able to determine their level of fibrosis, where in this pathway they are. And nowadays, we're able to do that by non-invasive testing to determine who is the patient that's at risk with their MASH. And the first test that's recommended for all providers that is meant to identify people who have high-risk clinical features. So people with medically complicated obesity or diabetes, those patients should be screened, and the first screening test we use is a FIB-4. So FIB-4 is not a perfect test. And you might hear a lot of bad things about a FIB-4, but what it's really good at is saying it is unlikely that you have advanced liver disease, especially at that bottom cutoff of 1.3. If it's less than 1.3, it's unlikely that a person will have advanced liver disease. It doesn't tell you that you don't have a little bit of liver disease. It doesn't tell you that you don't have moderate fibrosis. It tells you that it's unlikely that you have advanced fibrosis. Now, the nice thing about the FIB-4 is I'll show you later that if it goes up, if it starts to rise, it's a strong predictor of advanced fibrosis. So the point is that if you have a low FIB-4 and you have moderate disease, it will eventually start to rise before you get to that point of liver failure. And similarly, at that cutoff of 2.67, it increases the likelihood, meaning that you're quite likely to have advanced fibrosis. So we use those two cutoffs, a very, very low cutoff and a very, very high cutoff, to say it's unlikely that you have advanced disease or it's likely that you have advanced disease. And we use other tests to do the same thing. This is the enhanced liver fibrosis test. It's a lab test that's available through Quest and LabCorp, as well as some other labs. And it's three different components. Two of the components go up with liver fibrosis. One of them goes down. And by using those things, we get a score that tells us, hey, what's the likelihood of advanced fibrosis or moderate fibrosis? And what's the likelihood of cirrhosis or predictive of liver decompensation? So those are the cutoffs that we use. So above 11.3, there's actually not just a high risk of cirrhosis, but a high risk of liver decompensation. And above 9.8, that's where we say, hey, it's likely that you have advanced fibrosis. And then anything above 7.7, you can't be confident that they don't have moderate fibrosis, right? So when it's above 7.7, that needs a little bit additional testing to reassess their level of fibrosis, because it's likely that it's at least moderate. Okay, this is transient elastography. Usually we hear about this as in the term FibroScan, but there's a lot of other forms of elastography, shear wave elastography. RFE is another one that you hear. So I just want to say those names because what's at your center might be a little bit different. And we use the different cutoffs. Actually, I'll show you in the one in this first column. That's really what I want you to focus on. We use various cutoffs there to determine what's the likelihood that a person has moderate fibrosis or where there's a decent chance they have moderate fibrosis. And so I use that cutoff of 8. If their FibroScan or elastography gives you a KPA value of greater than 8, it's someone that has a moderate chance of having advanced or having at least moderate fibrosis. Once they're getting closer to 10, then there's a likelihood that they have more advanced fibrosis, stage 3. And then above 13, it's likely that they have cirrhosis. Okay. So you can see that the positive predictive and negative predictive values are not spectacular for all of these. But it's the negative predictive value that can be of use when you see that, at the very, very high level. So again, use this for what it's worth. It's very unlikely that you have advanced liver disease, or there's a very strong chance you have advanced liver disease. And as we've gone through these various tests, you start to pick up a little bit more resolution at picking the in-between stages, right? So FIB-4 is yes or no, right? ELF has some granularity to it. FibroScan probably adds a little bit more. And then the best test is probably MR-based elastography. This has been shown to have a 95% accuracy compared to liver biopsy. And what we use is a MR elastography cutoff of greater than 3.6 as detecting advanced fibrosis. So this is a technology that's available at Rush at our main campus. And it's been invaluable in my practice because we have people that come in with an abnormal fibro test or something else, or FIB-4, and maybe the FibroScan is equivocal. It's nice to have one more test that's very accurate that still can help a patient avoid a liver biopsy. Just an aside, we were talking about some of the clinical trials that have been done that have shown really high placebo rates in NASH. One of the reasons for the high placebo rates in NASH clinical trials is sampling variability from biopsy. When you do a biopsy, you sample 1/50,000th of the liver. And we know that if you sample 2 areas of the liver at the same time, that biopsy can vary by 1 stage of fibrosis 40% of the time. So it's not a perfect test. The nice thing about MR elastography is that you get to sample multiple areas of the liver. So in some ways, clinical trials, these companies are thinking about, is there other ways that we could assess fibrosis? And we'll talk about that a little bit later. Okay. Not only NITs helpful in, actually, we're going to talk about that right now. Not only are NITs helpful at determining the level of fibrosis, they can measure our assessment. They can assess our response to treatment. So this is a study that looked at FIB4 and changes in the FIB4, as I had alluded to determine what the likelihood was of developing liver-related events such as liver decompensation. And in the top blue, you see that those are the people with high baseline FIB4s. If their FIB4 increased, their risk of decompensation was higher. That's the solid bar. Versus if their FIB4 decreased, it went down. So that's the dotted bar. And you can see that for the indeterminate FIB4 as well as the low FIB4. Obviously, their baseline FIB4 is the biggest driver for their likelihood of having a liver-related event. Whether your FIB4 increases or not, if you start off in a low range, it's unlikely. And even if your FIB4 gets a little bit better, if you start off in a high range, you have a high likelihood of having a liver-related event. So again, FIB4 is not just a marker of fibrosis, but in this context can be a marker of prognosis. And then this is looking at it with elastography, looking at people with a high elastography value of greater than 10, a low elastography value of less than 10 in terms of advanced fibrosis, 10 to 19 as the intermediate, and greater than 20, which is associated really with cirrhosis and portal hypertension. And you can see that as your liver stiffness measurement, your FibroScan value increases, your likelihood of survival decreases. Right. So this is looking at mortality. And actually what's interesting is the CAP score, controlled attenuation parameter, is something we get during the FibroScan that measures liver fat content. So the level of steatosis, and actually the level of steatosis was also associated with survival. So it's just an interesting thing that we can now use these non-invasive markers to not just guess outcomes, but to guess mortality. ELF shows a similar outcome. And this is actually what ELF was created for, to determine who's going to decompensate. And so you can see that when your ELF is greater than 9.8, you have a much higher risk of progression to cirrhosis. This is of survival free of cirrhosis. And that's looking at the baseline hazard ratio versus the change in the hazard ratio, or change in from your baseline ELF. So again, kind of continuing that same pathway, this is looking at clinical trial data and saying, what does the MRI do? So like I told you, there's clinical trials that are just biopsy based, and they're not always the best outcomes because the placebo rates are so high. So people have looked for other markers that are better predictors. And the old Flint trial, which was obeticholic acid for fatty liver disease for NASH, what they found was that if your MRI PDFF, which measures liver fat, if that decreases by 30%, then you're far more likely to have histologic improvement. So now MRI PDFF decrease of 30% is actually one of the secondary outcomes in many of the upcoming clinical trials. And again, we see that now in the resmetirom trial, the Maestro NASH trial that led to resmetirom's FDA approval. We can see that MRI PDFF responders, meaning it dropped by more than 30%, were far more likely to have MASH resolution and improvement in the markers of MASH ballooning and inflammation than people who did not respond. So it's nice. Biopsy is becoming more and more obsolete, which is what we want. So ultimately, this is just looking at back in the day, we used to say, okay, who are the people that are going to get sick, right? Is it the people that have ascites? Is it the people that have hep C? Is it the etiology? And we never really knew. I was taught when I was in training that, it's all about how much portal hypertension they have. If they have more portal hypertension, they're more likely to have decompensation. But I mean, how do we measure portal hypertension? It's not the easiest thing. You have to put a catheter in their neck and measure their gradient, right? So that's not an easy thing. But what we're seeing now is that there's these non-invasive markers that can help us predict not only the development of cirrhosis, but the development of decompensation. So this is looking at MR elastography stiffness. And we can see that above 4.39, we have increased rates of not just cirrhosis, but liver decompensation. And then as you go higher, that's when you start to get complications of cirrhosis, ascites, hepatic encephalopathy, transplant, or death. And you can see these are the cutoffs that we are using to determine the risk of having cirrhosis, having decompensation, or being at increased risk for decompensation. All right, so what is the overall goal for treating patients with fatty liver disease, right, or MASLD? First, we want to find the high-risk population, and that's defined on the left. This is the ACE 2022 guidelines, which were published in conjunction with the AASLD. And the high-risk groups are those with type 2 diabetes, medically complicated obesity, so obesity with 2 or more cardiometabolic risk factors, such as triglycerides, dyslipidemia, diabetes, or not diabetes, that's already one of the groups. And then people who have steatosis on imaging or just elevated liver tests that you don't know the reason why. The overall picture is that you need to do risk stratification for those people, and that risk stratification occurs through the FIB4. If your FIB4 is intermediate, you need some secondary tests, and then the management is based on the risk of the patient. This is kind of like the histology slide that I showed you. If you're low risk, your focus should be on metabolic syndrome treatment. You can't ignore these patients, right? It's great that their liver didn't get sick, but if they die of cardiovascular disease or right heart failure from their untreated sleep apnea, you're not doing the patient any good. So it's important that we make the referrals and we do the screening that's required to treat metabolic disease. If they're high risk, then obviously they need to come and see one of us, and we need to start thinking about how do we better stage this patient? Do we need to do additional testing, or what type of treatments would they be eligible for? And then again, if they're indeterminate, that's kind of where we need to do the work to really figure out how high their risk is. So this is the AASLD practice guidelines. This is where I'm going to go into a little bit more detail about that screening pathway. So if a person is considered high risk, and I will include, in addition to what was in the ACE guidelines, I'll include people who have a first-degree relative with MASH cirrhosis. They have a 12-fold increased risk of developing advanced liver disease from MASH. The other group that's included in the guidelines are people who drink a moderate amount of alcohol. I'm not saying excessive alcohol use. I'm talking about within the CDC guidelines of what's considered safe. Moderate use can greatly increase the risk of an advanced fibrosis in people who have baseline MASH. So that's another group that should be screened. And you screen them with the FIB4. If the FIB4 is less than 1.3, those people can remain in their primary care or endocrinology settings. And the idea is that you repeat the FIB4 every 1 to 2 years if they're diabetic or have less than 2 cardiovascular risk factors, or every 2 to 3 years, if they have greater than 2 cardiovascular risk factors, or every 2 to 3 years if they have less than 2 and don't have diabetes. If they're greater than 2.67, again, that cutoff is predictive of advanced fibrosis. So that's a person that should be referred to GI or hepatology, at which point we'll do what's in the blue box, and I'll talk about that. But first, let's talk about the people that are indeterminate, between 1.3 and 2.67. That's a lot of people. There's been VA studies showing that this is going to overwhelm the system. And we're actually studying that right now in our internal medicine clinics, where we're instituting this care pathway and looking to see what kind of chaos it causes. So if you do have an intermediate FIB4 score, you need a secondary test. And the way you do that is either through transient elastography with FibroScan or another form of elastography, or the enhanced liver fibrosis test. If you have low risk by the enhanced liver fibrosis test, which is less than 7.7, then you go down to the low risk algorithm. And same thing with the VCTE. And then if you're intermediate or high risk, then you go to GI and hepatology. The cutoffs we're using, less than 8 would be considered low risk for a VCTE, and less than 7.7 would be considered low risk for an ELF score. Okay, so once they get to us, what do? First, we have to decide whether we think the diagnosis is accurate. Obviously, there's other things that can cause fat in the liver besides MASLD. We have to think about alcohol. We have to think about medications. We have to think about genetic disorders. And once we feel confident in the diagnosis, we also need to better stage the patient. If they haven't been adequately staged already, that might involve a liver biopsy, but usually not. And then we like to treat them based on their level of fibrosis. If there's not a lot of fibrosis, it's metabolic syndrome management. And then as that fibrosis increases, so does the intensity of your therapy. Obviously, once they hit stage 4 or cirrhosis, that's when we need to focus on cirrhosis-based screening and cirrhosis-based management. Okay, so these are the cutoffs that we're using to detect advanced fibrosis and or detect cirrhosis. So for the FIB4, Above 2.67 is indicative of advanced fibrosis. That's where you have to worry. And above 3.5 or so is where you worry about cirrhosis. For the ELF, greater than 9.8 is advanced fibrosis. Greater than 11.3 is cirrhosis. Again, 12 and 20 for the VCTE. The reason I'm kind of glossing over these is that there's no way in heck you guys are going to remember this. But there is an AASLD guideline that's freely available on the website that has all of this information for non-invasive testing and what cutoffs are recommended. And MRE is also included there. Okay, so how do we take care of these people? The first step is lifestyle management. So when Dr. Rowe and I got to Rush, one of the first things she insisted on, and this was, part of our debate last year, was that I get training in obesity medicine, and that we work as a center that focuses on the metabolic health of these patients. So I have very, very strong opinions on weight loss, diet, physical activity, etc. And some of the components of the slides I might agree with, some of them I won't. But overall, the principle is the same, is that you can't ignore it. Right? It is our job as GI and hepatology providers. We are now in a metabolic space. 30% of the population, 35% of the population has MASLD. We will see these patients. 16 million people will have MASH. These patients will be in our clinic, and we have to take care of their metabolic health as well as their liver disease. So, different thresholds have been set for what might be most effective. And first, in terms of weight loss, generally it's considered that 5% weight loss improves steatosis, 7% improves inflammation, and then to get fibrosis improvement or fibrosis regression, you really need about 10%. The diet that's been studied the most for MASH is the Mediterranean diet, which consists of lots of healthy plant or fish-based fats, low glycemic index or complex carbohydrates, and fruits and vegetables. One of the things that's probably not included in here that needs to be included in order to induce weight loss is protein intake. So you need a high protein diet in order to facilitate weight loss. That's really the nature's version of Ozempic. Of semaglutide. I don't want to lose our CME accreditation. So physical activity is also important. I take exception to the way these things are worded, right? So it's participate in a structured exercise program when possible, tailored to, there's a lot of cautionary tales, right? When talking about exercise. Of course, when we take care of patients, we want to tailor our treatment to the patient. But it's almost like you're scared, like these recommendations are almost scared to recommend exercise for our patients, right? It's about meeting patients where they are. If the only thing that your patient can do is lay in a chair and lift their legs up and down, have them do that 20 times an hour, right? So we shouldn't be afraid to give recommendations for exercise. And we should be aggressive with it because it probably is the most effective thing other than diet that they can do to not just improve their liver disease, but improve their mood, improve their metabolic health, and just improve their life in general. So be aggressive with exercise, so with the obesity medicine data would say that it takes roughly 300 minutes of moderate intensity exercise to induce weight loss and closer to 400 minutes to maintain that weight loss due to the physiological response that occurs once you lose weight. Coffee is the liver superfood. So it's been shown that coffee in a dose-dependent way can reduce the risk of advanced liver disease, especially in the alcoholic liver disease population and in the MASLD population. So if you drink a lot of coffee, I'm not saying I'm one of those people, but if you do, you're in good shape. Again, this is not the Frappuccino, ultra sweet coffee from Starbucks. This is black filtered coffee. Okay. So again, this slide is meant to say how much evidence is there behind a low-fat diet versus a Mediterranean diet versus keto versus low carb. All of that is unimportant. I'm going to say that very clearly. The diet you're using is unimportant. It's only about what your patient will actually do, right? If your patient loves intermittent fasting and they have a tremendous response to that, don't say, no, you should do a Mediterranean diet. That's what's working for them, right? If Mediterranean diet works because it's most flexible for patients, that's what it should be do because ultimately weight loss is king, right? So if the patient is effectively losing weight and maintaining muscle mass on a particular diet, that's what they should be going with. We do have to know that things like ketogenic diets that are high in fat can increase LDL cholesterol. Low carb diets can, especially when they're not associated with, they have been associated with a slight increased mortality, and low fat diets have been associated with sarcopenia, right? Meaning losing muscle mass. So you just have to tailor it. And if you're not sure exactly what to do, there's a whole group of obesity medicine providers in the Chicagoland area that you can refer the patients to. Most of us don't have time to do obesity medicine. And trust me, that's coming from an obesity medicine doctor that over time has had a clinic that's so full that I can't do it. And I rely on our APPs that are spectacular at it, right? And so we don't always have time, but there are people in this area, especially in Chicago, that have that ability. And so that's what we need to do. In general, there's really good data from Harvard looking at the effect of hyper-processed foods, right? So they did a study, a feeding study, where they looked at the same number of calories and the same macronutrient content, right? Here, talking here about changing the macronutrients, low carb, high fat, low fat, etc. But they took the exact same macronutrients and exact same calories, and people who had hyper-processed food gained more weight and had more metabolic complications, right? So thinking more and more about food that you make at home or that with ingredients that you can recognize that are not filled with preservatives is probably important. Okay, so looking at the Mediterranean diet, the one caveat I will give to this, the Medina trial, which is the largest study of the Mediterranean diet in patients with NAFLD, didn't show really a significant benefit over a low-fat, high-carb diet. So again, it's about what works for your patient. But the Mediterranean diet is effective for a lot of people, and it's been shown to reduce liver stiffness, improve insulin resistance, and reduce the fatty liver disease index. Intermittent fasting is really popular. Naomi Perella is the director of the medical program at our bariatric center, and she's also, I believe, the chief medical officer for one of the most common or one of the most popular intermittent fasting apps. And so she's really an expert with this stuff. And one of the things that intermittent fasting can do, at least the thought behind it, it's not that strong in terms of data, is to improve metabolic flexibility, right? So that when you're not eating anything, that your body goes into burning protein and burning fat. And that then you eat and you go back to burning carbohydrates because that's the preferential energy source. But if all we're doing all day is only eating a carbohydrate-heavy diet, that we lose the ability to burn protein and fat because when we have carbohydrates, we release insulin, and that causes a downregulation of the lipolytic machinery, right? So in order then when you eat fats and you eat other nutrients, your body has to make the proteins again to do lipolysis. So that's the big idea behind intermittent fasting. There's lots of different types of intermittent fasting. There's the alternate day where you restrict calories on one day and then you eat normally. There's the weekend diet, as Ali said, the YOLO diet. So it's during the week you eat, in a healthy calorie restricted way, and on the weekend you go crazy. Time restricted eating, that's the more common form of intermittent fasting, where it'll be 16 hours on, 16 hours not eating, 8 hours eating. So it was shown that intermittent fasting could reduce liver stiffness and liver steatosis in some small studies. Weight loss medications are a critical component of the treatment of MASH. The treatment of obesity, which leads to MASH. I have to be careful what I say because we're having this debate later on, and Dr. Rowe might use my words against me. But weight loss is key, right? And so if you have agents that can help weight loss, it's going to help the fatty liver disease. And so there's a lot of medications, orlistat, phentermine are some of the older medications, but still very effective. Not on here is phentermine and topiramate, which is also used as a combination medication that's been shown to have nice weight loss properties. And then we start getting into the GLP-1 therapy and the GLP-1 GIP therapies, which have kind of revolutionized the obesity field. But the other thing we have to start thinking about is alternatives. Either the patients don't tolerate those medications, they can't get access to them, which we'll talk about later. But endoscopic weight loss, like done by Chris Chapman at Rush, is an exceedingly effective way to induce weight loss. And there's more and more data that's emerging, especially with sleeve gastrectomy, and gastric balloon in terms of seeing reductions in liver fat and even some reductions in liver stiffness with sleeve gastrectomy. Finally, surgical weight loss is shown to be very effective, and we'll talk about that. In fact, we'll talk about it now. So this is looking at MASH resolution with bariatric surgery. And this is both with sleeve gastrectomy and Roux-en-Y gastric bypass. Gastric bypass is a little bit more effective in causing MASH resolution than sleeve gastrectomy, but both are pretty effective. And it's really depending on how much weight you lose. And so this is actually looking at point BMI drop. So if your BMI drops by 5 points, about 60% of people have NASH resolution. If it's 5 to 10%, 5 to 10 points of drop in the BMI, 80% of people have fibrosis, and if it's higher, closer to 90. I will give the caveat that this group, Lassalle et al. In France, they have the best outcomes for any bariatric surgery trial that I've ever seen. It's not the same with all of the trials. The other thing that's important here is that you see that their metabolic markers improve. And that's part of the reason why we see that bariatric surgery can actually lead to improved cardiovascular and liver-related outcomes. So in the green line, you see people who did not get surgery looking at liver-related outcomes. So that's liver failure or liver-related death. And you can see that they're far more likely to develop liver-related outcomes than people who underwent bariatric surgery in blue. And same thing with cardiovascular events. People who did not undergo bariatric surgery that have MASH were far more likely to have cardiovascular events. And again, this was one of the first trials that was specifically in patients with MASH. Okay, we talked about the fact that you have to optimize their metabolic health, right? So we want to have drugs that can target metabolic health that are also friendly to the liver. For example, statins. Statins are good for your liver, right? That it's not that statins are treating the liver, but though they cause a mild elevation in your liver test, doesn't mean they're bad for the liver. So we need to be able to give statins to treat dyslipidemia as appropriate. Type 2 diabetes. The new ACE guidelines recommend GLP-1 therapy as the first line treatment after metformin for most patients. And so that's something that we want to think about. If our patient has MASH and diabetes, how do we best treat their diabetes? We probably don't want to be giving them a medicine like a sulfonylurea that increases weight, right? We probably want to focus on medications that help with weight loss and might help the liver along the way. And then same thing for obesity, bariatric interventions, and medication-based interventions for treatment of obesity. So again, we want to optimize the treatment of their metabolic syndrome in a way that helps the liver. Okay, so this is obviously a ton of information. I don't expect you to absorb this, but what really we can focus on is where you should and shouldn't use these medications. So metformin, it's always been said that, if they have liver disease, you don't want to use it because of the risk of lactic acidosis. Really, that's not true until you get to decompensated cirrhosis. You want to use some caution in people with early cirrhosis, Child-Pugh A, but remember that metformin has also been anecdotally and actually in very large studies associated with decreased rates of HCC in patients with MASH. And so that's, something that you don't immediately want to just pull off their regimen. There is no histologic effect with MASH in a small study that was done. I'm still surprised by that result. But in a small study for MASH patients, there wasn't any major histologic event. Pioglitazone was actually one of the first medicines that was studied for MASH in the PIVENS trial, and it did show improvement in MASH histology. But it was a small trial with not really concrete endpoints. And so it's slowly fallen out of favor because why? It causes weight gain. But now we're talking about a different class of the PPAR. This is a PPAR gamma agonist. There's people that are looking at PPAR alpha and delta agonists and pan-PPAR agonists that are also showing promise in MASH. The GLP-1s, again, is safe in people through compensated cirrhosis. In fact, I'm sure Dr. Rowe will show you, and I will tell you that in people with compensated cirrhosis, GLP-1s have been shown to reduce the rates of decompensation and reduce the progression of liver disease. Insulin, it's one of those things where you just have to be careful once you get to cirrhosis because it can cause hypoglycemia. But it's a very effective treatment for getting your blood sugar down. That's probably the same thing with the SGLT2 inhibitors. The other things you want to think about is what's their cardiovascular risk, right? So if they have a high cardiovascular risk, maybe we'd be thinking about SGLT2s, now GLP-1s or semaglutide. And so again, it's all about tailoring the therapy to the patient and avoiding things that might be dangerous. But really, it's only once you get to decompensated cirrhosis that you have to start to worry. Okay, the next step in management is medication management. And so there's only one therapy that's currently FDA approved for the treatment of MASH with advanced fibrosis, and that's resmetirom. But the important thing is that I want to show you some of the clinical data behind approval for resmetirom. And there's two endpoints that are now the key endpoints for every phase 3 MASH clinical trial. And these are important to remember. So first, we're looking for MASH resolution. When we talk about MASH, we're talking about three main components: fat in the liver, inflammation, and cell death called ballooning. Those are the things that drive the liver disease. In order to meet the clinical endpoint of MASH resolution, there's something called the NAFLD activity score, and all of those three components are graded from 0 to 2 or 0 to 3. In order to get MASH resolution, all of the components need to go down to 0 or 1 for inflammation, and ballooning with cell death, that's the number one predictor of progression, that has to be a 0. So remember, when you see these clinical trials and you say, oh, only 35% of people responded, is that great? This is a really strict definition. We're not talking about improvement in MASH. We're talking resolution of MASH. So the goal is that we're actually stopping the disease, right? The goal of these medications is to actually reverse or stop the disease. And the second component is fibrosis improvement, where we're actually trying to improve the damage that's been created. So two endpoints: stop the disease, improve the damage that's been created, and ideally do both. Okay, so resmetirom is the first drug approved for MASH with advanced fibrosis. It's an interesting molecule. It is a thyroid hormone receptor beta agonist. So thyroid hormone receptor, for most of thyroid hormone works throughout the body using the alpha receptor. The beta receptor is really unique to the liver. And so this is a selective agonist of the beta receptor. So it's working in the liver without causing full body thyroid hormone effects. It was approved in March of last year for patients with NASH with moderate to advanced fibrosis. Okay, so what does it do? By activating, so MASH is associated with hepatic hypothyroidism, so defective thyroid signaling within the liver. By stimulating the thyroid hormone within the liver, we see a decrease in intrahepatic triglycerides, and that leads to improvement in inflammation, improvement in fibrosis. The thought is that by activating some of the mitochondrial activity, you get increased lipophagy. So it pulls it up. Also, you get increased beta oxidation. You also start making more mitochondria within the hepatocyte. So you end up start burning more energy. And so that's the general mechanism of action, is that it stimulates thyroid hormone in the liver, which starts burning the fat in the liver. Okay, so this was the clinical trial called the Maestro-NASH trial. It was a randomized double-blind placebo-controlled trial looking at 2 doses of resmetirom versus placebo. And the primary endpoints were what we talked about. Patients could have stage 1B, 2, or 3 fibrosis. The majority had stage 2 or 3 fibrosis. And it was 52 weeks of treatment. And then there was a biopsy before and after. You can see here that most of the patients had stage 3 fibrosis, about 60%. And they had metabolic syndrome. They appropriately had MASH. And 14% of the patients were on GLP-1s at the same time. And what they found was that about 25 to 30% of patients on the left, you can see there, had NASH resolution without worsening of fibrosis. And about 25% of people had fibrosis improvement by 1 stage with no worsening. And again, this is only after 1 year of therapy. The other thing that was kind of cool is that this medication was actually originally created as a cholesterol-lowering medicine. And so we saw that there's a dose-dependent decrease in the LDL cholesterol levels. There were some side effects of the medication. About 20% of people had diarrhea and nausea. Usually it was pretty self-limited, and the dropout rate from the trial due to adverse events was not that different from placebo, just slightly higher, and mostly at the higher dose of resmetirom. So diarrhea and nausea were probably the most common things. Usually what happens is it comes on in the first month, and it's usually resolved within a month of onset. But again, you have to tailor it to your patient. The dosing, usually it's given if you're less than 100 kilograms, you take 80 milligrams. If you're greater than 100 kilograms, you take 100 milligrams. You do have to review the medication. So sometimes there's dose adjustments that's required with certain statins. And also there are certain medications like cyclosporin, and I'm forgetting some of the other ones. Come to the talk on resmetirom, and I'll remember it by then. So that you do have to adjust. So, just something to think about. And importantly, this is for people with moderate to advanced fibrosis. This is not meant for people with cirrhosis. Okay. So if you suspect your patient has cirrhosis, they should not be on resmetirom. Okay. So what do the guidelines recommend? For the group that they don't recommend, that's people with cirrhosis, right? And how do you determine that? If your elastography gives you a kPa value or liver stiffness measurement of greater than 20, or your MRI-based elastography is greater than 5, you should definitely not be using this medication. They don't recommend concomitant alcohol use. I take a little bit exception to that because I think that people who have a mild amount of concomitant alcohol are the people that are at highest risk. And there was some data in the Maestro NASH clinical trial that Laura will present later, where the patients that had moderate use still garnered benefit from resmetirom. But the official guidelines are that we should not be doing that. Concomitant active liver disease. Again, I wouldn't ignore the MASH, but you also want to treat the concomitant liver disease. And then active thyroid disease, you just want to treat the thyroid disease before you initiate treatment with resmetirom. The people that it's recommended for, people with a liver stiffness measurement of greater than 8, by FibroScan or greater than 3.1 by MR elastography, or if you have liver histology or any other non-invasive test that suggests stage 2 to stage 3 fibrosis. And again, that's the group that it could be used for. All right. In terms of treatment, when you first start it, you want to check their liver tests. It's known that this medication can cause a mild increase in liver tests, 1.5 times the upper limit of normal in the first 8 weeks. Usually it gets back to normal 8 weeks into therapy, and then it actually starts to fall in the clinical trials. You should check their thyroid function, make sure it's normal. And if it isn't, fix that before you initiate treatment. I think the other things that are in brown are kind of you can consider doing this, right? So lipid profile, just to see if there's benefit or worsening. And then I think it's important that you measure liver stiffness. You're probably going to do that to initiate therapy anyways. But you would want to do that before you start therapy. They recommend checking a liver function panel about 3 months in. I check it about a month in. And the reason why is there was one patient out of 888 in the clinical trial that had a very high elevation of the liver enzyme. They had drug-induced autoimmune hepatitis that was associated with this medication, but it was only one patient. So just to make sure that you don't have that one patient, that's a place to check. Again, a mild increase in liver tests is normal, unexpected with this medication, but if it's sky high, that's a different story. Okay. And then, again, the other things are just kind of to keep an eye on things. And then at 12 months is where we really consider reassessing if the medication worked. And what they recommend is that if the non-invasive liver disease assessment is worsening, then you might want to reconsider your treatment strategy. You might want to consider a different medication. But if your transient elastography decreases by more than 25% and there's a normalization or significant improvement in your ALT, then that's probably a sign that the person's doing well and you'd want to continue the treatment. And if it's kind of equivocal, that's where you just have to reevaluate and see whether the risk and benefits are outweighed. Okay, the third step of management is where you call one of us at Rush and say, hey, let's get this person into a clinical trial because they have cirrhosis and I can't get them on resmetirom. And so are there any things that are available? Or is this person, maybe resmetirom didn't work and we want to think about what could work. So the good news is that there's a massive pipeline of agents that are being studied for MASH. There's other forms of thyroid hormone receptor beta. Resmetirom is being studied in people with cirrhosis. There's the bevy of GLP-1 receptor agonists, including the dual receptor and triple receptor agonists. FGF21s are probably some of the most exciting molecules that are coming out. You guys should all walk away from this study or from this lecture knowing that a single nucleotide polymorphism in FGF21 is associated with the sweet tooth. So how many of you have the polymorphism, right? I know I do. So PPAR agonists are another agent that's similar to pioglitazone, but it's a pan-PPAR agonist. And then there's the fatty acid synthase inhibitors like denifanstat, which are also being in early development. So lots to come when it comes to MASH treatment. Ultimately, this is a philosophical approach when it comes to treatment, right? So at early stages, we want to do treatments that don't hurt our patients. It's safety first. Lifestyle interventions never hurt anyone, right? And lifestyle interventions should probably be something that is continued throughout the spectrum. I have patients with decompensated cirrhosis that I'm constantly harassing for exercise because I know that if they don't, they're just going to do worse, right? So though it seems cruel, honestly, most of my patients end up thanking me at the end of it because it usually ends up prolonging their life. But in the early phases, right, we don't want to put them on medications that can hurt them or cause side effects. So we would focus on lifestyle. But once we start getting towards the more advanced liver disease, right, to F3 fibrosis, that's when we start thinking about, hey, yeah, certainly medications, but would this person be a good candidate for bariatric surgery, right? Because I don't have a big window. Once they get to cirrhosis and portal hypertension, bariatric surgery is not an option anymore. And when do endobariatrics fit in? So, right, it's all about matching the therapy to the severity of the disease. And I will just give one bit of caution. There's been recent release of data of the phase 2 data for tirzepatide as well as a GLP-1 glucagon dual agonist shows really positive data. And we're all excited about it and we want to see what the phase 3 data is. But the one bit of caution is that lots of medicines look great in phase 2, and for some reason, not all of them make it to phase 3 or are successful in phase 3. So we just want to use that with caution, and that should be something we think about before we start running to put patients on those medicines that are FDA approved for other indications. All right. So overall, NASH and MASH are growing in prevalence and complications. We now have non-invasive testing that can determine which patients are at highest risk. Our management of these patients must include treatment of their liver as well as their metabolic syndrome. And there is now an FDA-approved medicine to treat MASH with advanced fibrosis, resmetirom. And we need to identify these patients and refer them to us, GI and hepatology. So this is something that you need to communicate with your endocrinologist, your primary cares. And the more we can do to make that easier, the better, because ultimately we are going to need help, right? We can't do this on our own. There's 15 million people with MASH. Right. And so we're going to be using our endocrinologists, our primary care doctors. We're going to be needing care pathways. We're going to have to rely on obesity medicine experts and nutrition experts. We're going to have to find the people whose lifestyle change isn't helping because they have binge eating disorder. Right. So we have to start thinking about all of those components and building a multidisciplinary team that can really take care of these patients. And that is all I have. Thank you guys so much.